my hope is that your PCP is someone who is open and willing to have honest discussions. If you talk to them about your concerns around your weight, you guys have a discussion about how your weight may be impacting your health and whether or not you would be a candidate. It's always helpful if you can bring, if you have sort of direction, if there are specific medicines you have in mind, or things you would like to talk about to help guide the conversation. I think that's very helpful. And just trying to have an open and honest discussion about, whether or not you would benefit from that. If you think you would, you know, um, discussing that with your physician, and hopefully they are open. If they're not, as I've mentioned previously, and I made a video about this, I think the fault is on, if you are a good candidate, I think the fault is on them. I think the problem was this with them. It's not your duty to prove your lived experience. It's not your duty to identify whether or not you would benefit from that. The physician, it is their responsibility and obligation to do that for you. So hopefully they'd be willing to have that conversation. That's how I would think about it, and I would hope. And once again, if you come in with an idea of a medication or something, that's also helpful. You just talk to them about Wegovy like you would anything else. I think, the benefit of you already being on semaglutide is you say, listen, whatever reason you're on it, say, hey, I'm interested in this new drug. I heard it's the same medication, just prescribed at a higher dose, and I feel like I might benefit from it. And once again, kind of getting back to the other person's question, you just start having a conversation. Would you benefit from losing? What does Wegovy, what does the data suggest from Wegovy? Well, people on average lose 15% of their body weight with a combination of medication, diet, and exercise, so all the typical lifestyle things. In addition to that, there is a segment of those people who take it who may lose more. And because it's an average, there is a portion that will lose less. So we have to be aware of all the caveats. Not everyone's going to have this amazing response. That is part of biology. We know that people respond uniquely, and so we need to be aware of that and set expectations up front. I think that's important for patients so they don't get their hopes up and then they're disappointed if they don't respond like everyone. But certainly, a lot of you guys are bringing up good questions. Is it going to be expensive? How am I going to access it? Those are all things that need to be settled. I was looking up some articles today. I have it pulled up. What are the estimated what's the estimated cost going to be? Well, it looks like the investment, the R&D was about $1 billion for Wegovy, guys. B with a billion, 956 million. So you can imagine that Novo Nordisk, the drug manufacturer of Wegovy, is going to want to recoup some of that investment. So it is not going to be cheap, I imagine. And as we know with Saxenda, which is another drug they make that is very similar to Wegovy, if it's not covered by your insurance, it's expensive. So Saxenda is something like $1,200 to $1,300 a month in the U.S. out of pocket if it's not covered by your insurance. In Canada, it's like less than that. It's closer to like $700 a month. So out of pocket, but they have better coverage of medications if it's approved. No, I don't think it's not at either or. I would say it depends on the situation, what would be appropriate for you. Just because you have one doesn't mean you can't do the other. More and more, it's not a mutually exclusive scenario. More and more, they complement one another. And so oftentimes, I take care of many patients who have had bariatric surgery or who are contemplating it or who are in the process of being approved, and they're on medication because we are trying to help them lose weight here and now. And medication is something you can take longer. Obviously, surgery is it hopefully in most instances is a one-time affair, and you're done after that, and you just do your sort of routine follow-up care. But medications obviously will have to be continued for that effect to persist, just like with anything. Anything that works effectively, you have to continue it. At the moment you stop, you lose that effect, and so it is likely that weight will be regained upon stopping that medicine. GLP-1s have been historically covered for diabetes only. That was the FDA approved indication. This new indication for obesity only covers Wegovy, and then previously also covered Saxenda. So most GLP-1s will be covered for their diabetes indication. For obesity, I will tell you in my clinical experience, they are often difficult to get coverage for, and they're often restricted. So even Saxenda, that has been FDA approved for, I think since like 2013, would have to go back and look, may not be covered by your drug plan. And you might think, that's crazy. It's FDA approved for this condition. Why wouldn't it be covered? Because your insurance is not under any obligation to cover any medication. They're not under any obligation. So they can say, hey, life-saving medication here, I'm not going to cover it. And unfortunately, that's how our healthcare system works. It doesn't require insurance to cover specific medications. And so one thing you can do to get better drug coverage, especially if you have employer sponsored insurance. So if you are working for a big corporate entity and you have insurance through them and many thousand employees have insurance through them, what you can do is you can go to your benefit manager. So your pharmacy benefit manager in your company, you can call them up and say, hey, I want to request that Wegovy be covered on our formulary. And in fact, that actually has been quite effective a number of times. In the company, then they'll do a sort of analysis and look at it and say, does this make sense to include it on our benefits? And if it does, the company will pay for it and it'll be included and you can get it covered. So you can actually get it included into your formulary if you go there and request it via your benefit manager. Sometimes, usually they're like part of HR for any company, whoever the benefit manager is. So that's just another little tip for you guys about that. So let's talk about this because I get criticism for not covering the side effects, complications of any of these medications. Um, Although there's obviously limitations in what all I can do on one platform, but I know I get held to an incredibly high degree, a high standard. I'm okay. I can take care of that. But no, there's no negative effect for non-diabetic use if semaglutide is indicated for weight loss, right? So if Wegovy is indicated for the management of weight or obesity or managing obesity, then there's no unique effect that is a danger to people who are non-diabetic. People go, well, I'm concerned. I heard it's for diabetes. Is my blood sugar going to drop? No, and this is actually a really cool mechanism by which these GLP-1 drugs work. They only drop your sugar in the presence of sugar in your diet. So if you don't eat a sugar-loaded meal, meaning you're not having any carbohydrates in your meal, the GLP-1 won't cause insulin to release so that your blood sugars won't subsequently go down. So they're really cool. They only work in the presence of carbohydrates in terms of their insulin effects, in terms of their blood sugar lowering effects. So if you're not having if you're not having carbs in your diet, it won't drop your blood sugar. And so with that knowledge, we also know they don't cause hypoglycemia or low blood sugar. Typically, they only cause low blood sugar if they're also given with a medicine that does cause low blood sugar. So that's like insulin, that's like sulfonylureas, like liburide and all of the burides. So if they're given with another medicine that is known to cause low blood sugar, then yeah, they potentially could make that worse. But by themselves, they don't cause low blood sugar. That is a misconception around these medications. The big considerations for this medications. So in animal studies, so we call these preclinical studies, they're before the human trials, before the clinical studies. In animal studies, that's where you prove, is there any type of effect for losing weight or whatever drug effect you're trying to set out for. And if you can't prove it in a mouse study, then they don't even go to clinical trials. So that's why the proof of concept has to be in an animal before they will do it on humans. That makes sense intuitively, right? So in animal studies, there was an increased risk of thyroid cancer, particularly thyroid cancer that's a special type called medullary thyroid cancer. They also saw an increase of cancer in people that had, or people, in rodents that had something called MEN2 syndrome. It's a very rare syndrome, multiple endocrine neoplasia syndrome type 2. In humans, we have not seen that same association. So they've done a recent meta-analysis, came out last year. A meta-analysis is just an aggregate of a bunch of studies, meaning you're just looking at like 50, 60,000 patients over the last 5-10 years. Have we seen an increase in thyroid cancer and MEN2 syndrome and all these different things that were concerns in the animals? No, we have not seen it. Does that mean there is 0% risk or no increased risk? No. It means that probably if there is an increased risk of any of those things, It's very, very small. It's not significant to the point where we would really, really be worried about it. But there may still be a risk. So that's why we talk to people if you have a personal or family history of thyroid cancer, not thyroid disease. I have a lot of patients that say, well, I have hypothyroidism. I don't care. Has no impact on your thyroid disease. We're talking about thyroid cancer. Then it's something that you should have a conversation with your doctor at that point. Okay. Other side effects that should be worried about. There is this theoretical concern about causing pancreatitis. So if you have a personal history of pancreatitis, it's something that you should discuss with your doctor, whether or not you would be a candidate at that point. That's really the biggest ones that we worry about. There's this other concern about retinopathy, which is really, born out of this idea that if you're someone who has very advanced diabetes, you have advanced diabetic retinopathy, or you have some early diabetic retinopathy, this medication may dramatically lower your blood sugar. You might think, okay, that's a really good thing. We know that in people who drop their blood sugar quickly via drugs or lifestyle, and they have a history of very poorly controlled diabetes, that can worsen some of the complications of diabetes. Microvascular disease, meaning disease that affects the small blood vessels of the eye, that may get worse. And so that's something that we're monitoring right now. It's also why some of the guidelines recommend for people with long-term diabetes not to go below an A1C target of 7%. There's a lot of debate on that. So I would just tell you that is another theoretical concern. Side effects, though. Most of the side effects that we see with these drugs, the most common side effects are GI related. Constipation, nausea, in some cases diarrhea and vomiting in very rare cases. I have a patient right now I saw today. He had diarrhea when we went up on his dose of semaglutide. What we know that you can do is you can go back down to the lower dose. You can stay on that dose a longer period of time and then retrial them at the higher dose. If you do that, in many cases, including cases I've taken care of myself, people will resolve that side effect. Your body develops a tolerance to the side effects over time. Now, if you're someone who develops debilitating side effects at the lowest dose, it may not be a thing. You may not be able to take the medication. But for many people who only develop side effects later at higher doses, you may be able to keep them at a lower dose for a longer period of time. This is not something that a lot of doctors know about. This is something I know about because it's something I intimately deal with. So I would just educate you all if you're someone who's like, I only started having, significant nausea at 1 milligram or at, eventually what would be 1.7 and 2.4 for semaglutide. Well, you may be able to go back on that lower dose, just stay on it a little bit longer, several weeks, give your body some time to adjust, then try to go back up on it. That's a strategy that's proven helpful. And I may make a video about that for doctors and providers alike to refer to, and you can take to your doctor because I think that might be helpful as we see more and more people start prescribing these meds.